So, what is tobacco and what is this gutka chewing?
This gutka is a mix of tobacco along with erica nut, certain spices, sometimes paraffin wax, and many other things. And after the ban of gutka, what they've done now is most manufacturers, they don't put tobacco in the gutka. They buy pouches of tobacco, mix it with this preparation of slake lime, erica nut, spices, and they make their own gutka and they eat. Okay? Supari is now a known carcinogen. Okay, it has been classified as a carcinogen by IARC. Wherever we go for a wedding or we go for any kind of cultural activity, we are gifted pan. In fact, we offer pan to the gods also and everything, right? So we believe that it is of cultural relevance to us. But what we don't know is even betel quid is foreign to India. Nicotine that is present in tobacco is one of the most addictive substances. I have seen a patient who has had a laryngectomy, so he has had his voice box removed and he's breathing through a hole in his neck, but even through that hole in his neck he's managed to smoke a cigarette.
Welcome to OncoFlix podcast. I am Dr. Lohit Reddy, consultant radiation oncologist at HCG Hospitals, Bangalore.
And I'm Dr. Kritika, consultant radiation oncologist at HCG.
Chewed, enjoyed, spit. But cancer doesn't forget. What am I talking about? You're talking about tobacco and gutka. And today we have with us our expert, Dr. Shalini Thakur, consultant Epidemic surgeon at HCG Hospitals, Bangalore. Thank you for coming on our show, Dr. Shalini.
Thank you for having
Welcome,
me.
ma'am.
Thank you.
So, what is tobacco and what is this gutka chewing?
Yeah, I think that's a very important question to answer, especially for our country, because not a lot of people know what exactly gutka is, what is pan masala. Even the people who use it don't know.
Correct.
Yeah.
So basically, what we need to understand is gutka is a mix of tobacco along with erica nut, certain spices, sometimes paraffin wax, and many other things. And after the ban of gutka, what they've done now is most manufacturers, they don't put tobacco in the gutka. Okay, but of course, Indian jugaad is the famous Indian jugaad. What people do is they buy pouches of tobacco, mix it with this preparation of slake lime, erica nut, spices, and they make their own gutka and they eat it. Okay, pan masala on the other hand is dehydrated contents of the pan, the betel quid.
Okay.
Okay, so this is just basic information about what, and these are basically chewable forms of tobacco and tobacco related products, which is very commonly used in our Indian subcontinent, and it is the cause for many diseases which are very specifically seen in our country.
So, do you think there is a difference with respect to this chewing of pan masala or gutka with respect to rural and urban? Do you think it's more in the rural because it's easily available, cheaper than candies?
Yeah, absolutely. See, what we need to understand is our population is still largely rural. Okay, and tobacco was introduced into our country as a smoking form. This was introduced by the Portuguese in the smoking form. But because by then there was a prevalence of chewing pan, right? It was very easily incorporated in the chewable form in our country, especially in the rural populations. 60 to 70% of tobacco use in the rural populations is in the form of chewable tobacco, not only in the males but even in the females. Okay, and this is a huge number. If you see, like you said, it's cheaper than candies. So if you see the amount of money that they will spend each time they go to buy this, if they were to go and buy things like cigarettes, they would probably be spending close to about 30-40 rupees. This is according to some surveys where for each purchase you'll spend about 30 rupees for a cigarette. Compare that to a 12 rupee that they would spend either for a BD or for a gutka or a pan masala, right? So because of that, this use has become very prevalent, and not only amongst the male but also amongst the females, where it is socially acceptable to be chewing pan and putting tambaku or hoge sappu as it is called in Karnataka to it is not a big deal.
Correct.
So that is why it is readily available, readily accessible. It is more like a cottage industry.
Exactly.
Right.
Yeah.
So which is more dangerous? Is it arecanut? Is it the lime paste? Or is it actual tobacco which is causing you damage in the oral cavity when you chew these products?
Yeah, so that's also again a very important question, because people only talk about tobacco. Wherever you see the chapter
Correct.
is about tobacco.
Mhm.
What we don't understand is that betel quid, each component of that betel quid is a known carcinogen.
Mhm.
Okay, beginning with the betel leaf itself,
Mhm.
which also increases the amount of radical oxygen species that can cause, that can have carcinogenic effects in the body. Along with that, the slake lime, which is like a toxic substance, it's a caustic substance
Correct.
basically, which can cause irritation. Then the erica nut. Now, erica nut, which is most commonly known as supari.
Super.
Okay, supari is now a known carcinogen.
Okay.
Okay, it has been classified as a carcinogen by IARC,
Mhm.
and this not many people will tell you. In fact, the supari packets are still, they are regulated by FSSAI, right? It does not even come under the. Yes, absolutely. So it's sold with the food and beverages in every store that you can go to, but it is a known carcinogen. Just like that, tobacco, the chewable form of tobacco, a lot of people who smoke tobacco go ahead and start using chewable forms thinking it is less toxic.
Replacement. Yeah.
But chewable forms of tobacco have close to 3,000 chemicals in them. Out of that, 28 of them are carcinogenic.
Mhm.
Supadi, the byproducts of supadi, like aricolin and all of this, again, they get metabolized into carcinogens, okay, nitrosamines. All of this can cause DNA damage, and they are mutagenic, carcinogenic, whatever you may call. So if I have to rank them, of course, the number one carcinogenic agent in all of these things is tobacco. After that, I would say erica nut or supadi, and then slake lime.
And there's a mixture as well. A lot of people mix all these three components to
Yes.
create that better effect or probably feel that well-being in them.
Absolutely. And it's so socially acceptable. That is the problem.
Yeah, so when we speak of this gutka pan and this areca nut and betel leaf, there are two kinds of things that come to our mind. One is gutka and pan chewing has always been portrayed as negative things. You may get
Correct.
cancer. But culturally also, people are used to using betel leaves. Probably they remove the quid. They use the betel leaf with that chunna and areca nut as a cultural practice itself.
Absolutely.
So from our conversation, we understand that although tobacco could be the most leading factor for carcinogenesis, these other substances also could act as irritants.
Absolutely.
And are associated with cancer. So it's not just that gutka or pan which has the tobacco, it's also these substances.
So if you see cultural, pan, basically wherever we go for a wedding or we go for any kind of cultural activity, we are gifted pan.
Correct.
In fact, we offer pan to the gods also and everything, right? So we believe that it is of cultural relevance to
Exactly.
us. But what we don't know is even betel quid is foreign to India.
Okay.
Even though it has come some 2,000 years earlier, it has come from Java, Sumatra, betel quid, the betel nut and the betel leaf have come
Leaves
from there.
also,
Yes,
yeah.
they've come
So
from
you
there.
mean to say even betel leaf is not advisable? Just the betel leaf, because there is, we do get, you go to marriage function, you go to, any temple, you do get as a prasad or, some
They are
kind of
known
a
irritants.
token of appreciation. Otherwise.
They are known irritants.
So probably
irritants.
the level of irritation may not be as high as with everything.
Maybe not.
Yeah.
Just the betel leaf.
Just the betel
But
leaf.
the betel nut or the erica
nut
is
yeah.
a definite carcinogen.
Right.
And nobody eats the betel leaf
Alone. So it's very rare to see people eating it alone.
They will put slake lime too.
Right. Slake lime.
Yeah.
And areca nut. That
areca
always goes in hand.
Right, the three goes together. So when you add slake lime and areca nut to the betel leaf, it is a very toxic combination.
Right.
For sure. Because what happens is that the betel nut, like I said, it is a known carcinogen. The slake lime, okay, the pH of the slake lime is such that it is caustic, and it can even cause abrasions in your
Acidic.
mucosa. Yes. No, it is caustic.
Caustic.
Yeah,
it's a reverse.
It's the reverse. Okay?
Right.
So the pH is quite
alkaline.
high. Yeah, it's alkaline. And it can cause like abrasions and cut. And with chronic use, like with long-term use, this inflammation. We all know cancer
Repeated
is a
injury.
form of
Yeah.
long-term inflammation, and that is how it increases the risk. And betel leaf, even though they say it has a lot of
Ayurvedic
medicinal
properties.
properties
Exactly.
and all of that, but it is not meant for long-term chronic use. It's not meant for that at all.
Anything with long-term abuse is always something.
Yes. Now, if I tell you a story of this girl, okay, I remember this is from my training days. This lady who was about 40 years old had come to us with a buccal mucosa cancer, that is a cancer of the cheek. She came, and I was a little at that time, I used to scold people a little bit also. So I told her, why did you, why did you go ahead and use this? And that's, the reason you have this cancer is because you've been eating pan for so long now. Then I see that her daughter, who was around 17 or 18 years of age, she herself had a betel quid in her mouth at that time. Okay. So what she said was that she started eating when she was 13. I started eating when I was 13. And this is a culture that has been ongoing in our village. All the girls, when they turn 13, it's like a rite of passage. They start eating the betel quid, the pan.
And it does stimulate them also.
Yes, 100%. 100%.
That is how they continue chewing it.
Yes. And nicotine that is present in tobacco is one of the most addictive substances. It is more addictive than heroin. Okay. Right. So to give up this habit without the means or without access to proper help is next to impossible.
Right.
Like even with help, the quit rates for tobacco are very low. They stand at about 6 to 8%.
Right.
So imagine without even access to primary healthcare in most of these villages, these women have no way of leaving this habit.
Correct. So you see probably around 50 patients in your clinic every day. How many of the ethnic cancer patients who present to you come up with chewing habits, or probably the causative factor is because of chewing tobacco or tobacco products?
Yeah. So tobacco and tobacco related products contribute to about 90% of the patients with oral cancer. Okay. In our clinic, definitely 90%. And this is world literature. I mean, and in India, it is definitely 90% and above.
Right.
And out of them, I think chewing forms about 60% must be using it in the way of chewing. Okay. More urban people and especially urban men are the ones who will smoke the tobacco, but most of them will chew. And gutka is one of the most common ways in which people, even youngsters, are using tobacco these days.
Right.
Okay.
So the chewing rate of tobacco is more alarming than the smoking rate.
Yes, in India, definitely, which is why we are the world's highest contributor for lip and oral cavity cancers. 48% of lip and oral cavity cancers come from India.
So do you think this habit of chewing alters their outcomes to treatment compared to somebody who doesn't have a chewing history?
Yeah. So that's a very interesting question. Now, if you look at the patterns in which oral cancers, occur. So if you look at a patient who has, let's say, tongue cancer, floor of mouth cancer, these cancers are most commonly present in those people who smoke, right? When they chew, so in chewing, the most important thing that they do is they park. They park the tobacco in a certain area, most commonly between their cheek and their gums. So this is why in India we have it's called the gingival-buccal cancers. This is called the Indian cancer.
Right.
Okay, that is the most prevalent cancer.
Yeah.
Okay, and gingival-buccal cancer, it is notorious because it can invade the bone. It can involve the bone very early, and because of that, they usually present at a late stage. They can involve the skin, they can involve the bone, and because of that, they almost always have to have these structures removed, and it can cause a lot of functional problems. Not that tongue cancers don't pose a challenge, but gingival-buccal cancers, buccal complex cancers, pose a special type of problem because of its early involvement of bone and skin.
But if we do the standard treatment, do you think there will be a difference in outcome also?
Yeah, because standard treatment outcome differences, of course, we'll have to look into more, doing more studies to establish that. But a number of second primaries also that you see are very high in people who chew. Okay.
Field cancerization.
Yes, because of the field cancerization, and also because they'll almost always have potentially malignant diseases such as OSMF. Okay, and the kind of treatment that you need to do for them, because most of them will come to you with very small mouth opening.
Right.
So the kind of treatment that you do for them the kind of mouth opening, the quality of life that they have after surgery will be much poorer than those who smoke. But that's not to say that people who smoke and have cancer, they do very well.
How difficult is it for a patient to let go of this habit even after hearing the word cancer, which is such a fearful word for the public?
Yeah.
And even after treatment, when patient is potentially controlled or cured, how difficult is it for a patient who let go of this habit?
So that's again a very important question. Now, we have seen that one of the most common cause of post-operative discomfort in patients whom we've treated for oral cancers has been because of their dependence on nicotine. Because up until their diagnosis or up until their surgery, sometimes they continue to use tobacco, they continue to chew. Okay, and then we suddenly put them in a state where we give them no tobacco at all, and they definitely go in for withdrawal.
Mhm.
During treatment, it becomes very difficult for them because they're not eating orally. They are getting radiation, they're having their own problems, of course. So during treatment, which is about 3 to 6 months, they may not be using tobacco. It becomes very hard for them to. We have seen that most people after 1 or 2 years go back to
Resume.
using. Okay, when I say most people, I don't mean all of them, of course, but people who we know have a higher dependence, they do go back in the first 1 or 2 years. If I have to put a number to it, I think about 10 to 20% of them will go back to using tobacco in one way or another, tobacco or alcohol.
And do they also come back with disease?
100%. In those patients whom I've seen who've gone back to the habit, most of them have come back with a second tumor. Yeah, second tumor. When they should have done very well, they come back with another.
It is either in the same place or it is adjacent place or is it in another site?
Yes. But they do come back. And also what we have to know is that, even if a person is not able to give up tobacco with cancer, you can imagine how bad the addiction
Right,
is.
the level of addiction it is.
Yeah,
and we are very sure that your team makes so much effort to make them understand that this is what has caused it, and you put them through a lot of clinics,
Rehabilitation.
psychosocial support to get rid of the habit, and still if they go back,
they have first-hand experience of what tobacco has done to them and their family, and yet they find themselves helpless in front of this habit. Okay, I have seen a patient who has had a laryngectomy, so he has had his voice box removed and he's breathing through a hole in his neck, but even through that hole in his neck he's managed to smoke a cigarette.
Addictions per se itself could be a major
fact.
Absolutely. And the problem, see, alcohol, if somebody is an alcoholic, that is dependent on alcohol, he is ostracized by the society. His home people, he's a drunkard. They label him, they stigmatize alcohol use. But nobody stigmatizes tobacco use.
Exactly.
Because of which I feel that tobacco is a bigger menace than alcohol is currently.
Yeah. So when we talk of tobacco chewing and cancer, how long does it take for somebody who's chewing tobacco? Let's say he started today. How long does it take for him to get a cancer?
Yeah, okay. So this is an interesting question again because it depends on how many times a day he has taken, he has chewed tobacco. And also one more very important factor is whether he's spitting it out or he's keeping it in his mouth. The duration that he keeps in his mouth is extremely important, so much so that they have seen that 13 times more risk of developing cancers has been found in people who park the gutka or pan in their mouth.
Right.
Okay. Not just oral cavity, but upper aerodigestive tract. Okay, because they drink the
Juices.
the juices of the pan.
Yeah.
So it depends on all of that. But on an average, I think 1 to 15 years. Now it's a wide window.
Right.
Again, it depends on the individual. Okay, it depends on socio-economic status. Okay, because the kind of food that they are eating, the kind of oral hygiene that they are maintaining.
What are these precancerous conditions, and can you elaborate on the same?
Yeah, so the premalignant lesions are the red-white lesions, okay, which is called leukoplakia or erythroleukoplakia or erythroplakia, which is a red lesion. Then you have something called lichen planus. Now this can be either acquired or it can be, it is an immunomodulated lesion. So you can have white patches all around the mouth. Okay, and then you can have something called oral submucous fibrosis, which is very commonly associated with the chewable form of tobacco.
Right.
Okay, not chewable form of tobacco. Actually, it is associated with the use of erica nuts specifically.
Erica nuts, right.
Okay, so erica nut is the one that actually causes this submucous fibrosis. How it does it is that the erica nut, when it is eaten with slaked lime, actually, like I said, it's very caustic and it causes a lot of injuries. Even the process of chewing it, because it's such a hard substance, causes a lot of chewing. Now, when you're doing it on a daily basis, what happens is these chemicals that are present in the erica nut, okay, they are basically carcinogenic. Ericoline especially is a carcinogenic agent. Along with that, what it does is, because there is so much injury, the body is trying to heal it. Okay, so it heals by laying down fibers or collagen. Right, and the other substances like your slake lime and even erica nut has some copper. All of these actually strengthens the bond of these fibers, and because of that, the tissues on the inner lining of your cheek, which is supposed to be supple and allow for mouth opening and various other movements in the mouth, becomes hard. Okay, and because of that, your mouth opening reduces. It begins with burning of the mouth and intolerance to spices, but then it progresses to you not being able to open your mouth, move your tongue, and a lot of other problems.
So, what are the first signs of somebody who's addicted to tobacco chewing that it has started affecting their oral health?
Yeah. Okay. So, the first sign I would say is burning sensation. I think that is the one thing that most people will present to us with. They'll say that I'm having intolerance to spices. I'm not able to eat anything spicy. And when you examine them, there will be multiple areas where, there'll be denuded mucosa, that is, the red mucosa, not pink, healthy mucosa, but reddish mucosa.
These are irritated.
Irritated, yeah. Irritated mucosa. And other than that, I think they may start to have certain dark pigmented patches. Okay, all of that is also, that's not a sign of cancer per se, but the sign that a person is using tobacco very heavily. Okay, and but I think one of the first signs that you need to watch out for is burning sensation.
Burning sensation. Yes. So that means it has started showing its effect.
Yes.
So many people suffer with vitamin deficiency. You see aphthous ulcers. Okay, aphthous ulcers is nothing but small, ulcers which come in the oral cavity.
Yeah.
Or, if there are any ulcer, especially tobacco chewers and smokers, you see ulcers which probably persist for more than 3 to 5 days or 7 days.
Yeah.
Do you suggest them to be evaluated by a doctor, or is it a sign of cancer?
Yeah. So, my dictum is that any problem that is persisting for more than 15 days,
15
to 20 days, if there is any problem that is persistent for 15 days, get it evaluated. Okay, if you are seeing a wound that is not healing, especially if you are a tobacco user, because you are a high risk group. Okay, so if you are a tobacco user and you're seeing a wound in your mouth that has not gone away for 15 days, go to the nearby doctor. It can be a physician, it can be an ENT specialist, it can be a dentist. Please go and get checked. Okay, that is the least you can do to keep yourself away from cancer. Not to say that any ulcer, like now this should not create fear mongering. Not every ulcer is cancer.
Correct.
Ulcers, like you said, aphthous ulcers, or even,
these are the commonest ulcers.
You may bite your cheek, and there may be a lot of reasons why you may have wounds in your mouth.
Yeah, but stress, vitamin deficiencies.
Absolutely. Typically, the body will heal that in about 1 to 2 weeks.
2 weeks. So generally 3 weeks is the mark?
Yes. I keep it at 15 days for high risk group.
Right. Okay. So, with respect to these tobacco-induced damages in the mouth, yes, some set of damage. Let's say somebody has started having burning sensation in the mouth. Is there anything that they can do to reverse it?
Quit tobacco. Okay, but even that does not reverse the effects that have already occurred. Okay, then there are certain medicines that can be given to them. Certain, we call them chemopreventive agents, which can, there is a lot of evidence to suggest that some may work, some may not work. Okay, it is highly debatable the use of chemopreventive agents right now to reverse the signs of or the injuries that are caused by tobacco. But generally, problems that have started, they do not reverse.
So damage is easy, repair is very difficult.
Absolutely. So the only thing that you can do from then on is what we call, primary prevention, which is to get screened and to prevent the disease from actually happening.
What do you suggest as a chemopreventive strategy, and does supplements like antioxidants create an impact in reducing the damage?
If you ask me, antioxidants are abused. Okay, like we load ourselves with toxins and then we feel that using antioxidants actually will reverse the damage that has happened. I think we've established that it does not. But having said that, there are certain drugs that have shown benefit. Drugs like vitamin A derivatives, okay, certain retinoids, retinoic acid, and all of that have been shown to have benefit. Along with that, nanocurcumin has been shown to have certain benefits. Okay, so I would say that don't abuse another drug to cure yourself from the harmful effects of another drug that you were abusing. I would suggest getting medical help in managing your condition.
So when we talk of screening, both with breast cancer and cervical cancer, which are the first and second most common Indian women cancers, there is an established screening program. When we say 90% of oral cancers are tobacco associated, why is there no established screening program?
Very interesting question. See, population based screening programs for oral cancer have been tried for a very long time. But people who use tobacco, people who know that they are at risk for developing tobacco, will not come to these screening programs. Whenever you go to screen people in villages, only those who don't use any tobacco are health conscious, only these people turn up at screening programs.
Is it because they are scared?
Yes, they are scared. Okay, and they know that they are doing something wrong, and they know that this can cause cancer, and if I go there, something may get picked up. So
what if they
denial.
say that there is a cancer?
Yes, that's a form of denial. Another thing is, one of the most frequently cited paper, okay, on oral cancer screening was by Dr. Shankar Narayanan. Okay, so he had screened a population in Kerala, and you can go back and read this paper. It's a very nicely done paper. So he basically, in short, if I have to tell you, what he saw was, if healthcare workers are trained to just ask people, do you smoke, do you drink, do you use tobacco, and screen them from time to time, okay, it reduces the mortality associated with cancer by 27%.
Right.
So to say that simple measures can actually bring about a lot of difference. Screening is very important for oral cancer.
It can be detected early?
Yes, it can be detected early. And just educating them slightly, taking 2 minutes to educate them and to say quit, just to put that seed in their mind, is very important to, in a population level, to reduce the burden of oral cancer.
Right.
But if we are not able to do it in a population based format, at least we should do it opportunistically. So this is to all the practicing physicians and to the dentists. Whenever you see a patient in your clinic, you must make sure that you ask a question. Do you smoke or do you use tobacco? And take 2 minutes of your time to educate them as to why they should quit.
Perfect.
So, and it has been known to be, effective. In fact, the Dental Council of India had actually trained dentists, a group of dentists, and given them a kit for tobacco cessation. And then they found that these people went back and screened, in their clinics, and they found that there was a 11% quit rate. Now, 11% quit rate sounds low,
yes,
okay,
but it's significant.
Yeah, the established quit rate is 6 to 8%. Right. So this was better than that.
Right.
So what I'm saying is that I think we as physicians have to start taking ownership.
Wow.
And like initiatives to make people quit.
When we see, a lot of film celebrities like Shah Rukh Khan, Ajay Devgan, Akshay Kumar, promoting, something like Vimal Elaichi. Do these products also have carcinogens in them? Are they also a risk factor for causation of cancer? And does the government have to put in probably a tag behind the cover telling that, okay, these products are also harmful?
So, very interesting. And I think this is very relevant in today's time. Vimal, Ilaichi, all of these are surrogate marketings, right? We know that they are not marketing, and the consumer knows that they are not marketing the Ilaichi packet. Okay, they are marketing for the gutka.
Okay.
Right? But because they are not allowed to market for tobacco, even for
Very interesting.
that is why they use something like Bolo Zuba Kesari, eat ilaichi, and it is just a form of surrogate marketing. And this has been done for a very long time. But when it is endorsed by celebrities such as Shah Rukh Khan, Ajay Devgan, Akshay Kumar, what it does is it kind of, these are people that, especially people in rural India, look up to.
Yeah.
They want
Absolutely.
to be like them. They want to dress like them.
Correct.
So it is, I think they should take it with a little more responsibility to see what kind of role models they are creating. For pan masala, there should definitely be a warning. They have advertised for Vimal Ilaichi. He goes to the shop and he says Vimal, and he gets Vimal gutka or pan masala. Right. So that's how the marketing works.
Right.
Okay. So that, which is why I said, I think that the celebrities who are endorsing these products have to take a little bit of responsibility.
Become more conscious.
Become more conscious as to what is this impact on society, on their fans, on these people who actually, they revere them. Yeah, yeah.
So, do you think putting a warning sign makes a difference at all?
100%. In fact, if you take the example of the cigarette box, okay, 80% of that now has a very graphic image.
Correct.
Like when we started, like if you remember when we were children, cigarette packets used to have Marlboro Man.
Correct.
A cowboy on a handsome looking cowboy. Now, and then it went on to that obscure looking X-ray showing some lung area, something like that. But now they have mandated that, it should have a very real patient with a nasogastric tube, feeding tube, and a large wound on the face is there on the cigarette packets. In fact, the GATS data has shown that there has been a 70%, like 70% individuals have been motivated to quit just looking at the cigarette packet. Right. Looking at the cigarette packet. So having warning labels does help. Okay, does help, but it does not help when it is some obscure one-liner written over there. It has to be graphic. It has to portray the truth. Only then does it work.
Yeah.
Tobacco packets as of now do have. Right. Erica nut, even though it has been recognized as a carcinogen, it still comes under food safety, like I said. And they are not mandated to give such warnings.
So when we talk of the financial aspect of treatment, so people do have insurances these days. Both the smoking and chewing, any form of tobacco addiction, makes them ineligible for treatment or insurance coverage of cancer?
So it depends on whether they have disclosed whether they are tobacco users. So if they have disclosed at the time of getting their insurance that they are tobacco users, they have to pay a very high premium. That is why most people don't disclose. And yes, if they have not disclosed and they are tobacco users and it is a tobacco related illness, they are liable to be denied insurance cover for their treatment.
So this is a very important point for the public to note, that if you are a smoker or chewer and if you haven't declared it, then your insurance may reject if at all you develop a cancer. On the controversy, none of your companies will be willing to give you an insurance. The companies, I mean, are the cigarette companies or the gutka companies will be willing to give you an insurance. None of them.
Absolutely right. In fact, I tell many of my patients this, that, at this time of your need, okay, you've been so loyal to a substance for majority part of your life, 20, 30 years. It's been your friend. You've considered it your friend and you've given it your loyalties. You've given it so much money. Today, is it sitting with you at the time of your need?
Exactly.
It's not. Okay, it has literally destroyed your life. But those company people are not coming and sitting with you. Those heroes who are endorsing the products are not sitting with you, not paying your medical bills.
So probably the solution is, instead of putting a warning, let them issue a 5 lakh medical insurance for every user who is going to take that pan or gutka.
So I think if if the public is watching this and if they want to quit tobacco usage, where do they go for help as of today?
Yeah. So the first thing that they need to do is that they need to seek a physician's help. Now, whoever is their family physician or a doctor nearby, sit with them and understand what are the harmful effects of smoking. See, smoking and using tobacco in any form. See, the what we need to understand is that the problem with quitting nicotine is the lack of motivation.
Right.
Okay, if a person is not motivated to quit, no matter how many medicines you give them, no matter how many
Right.
drugs you give them chewing gums, you give them patches, nothing is going to work.
Right.
So they need to be motivated to quit. And sometimes that motivated can come from a loved one. Sometimes it can come from a doctor telling you that these are the things in your health that are showing that, tobacco is having a bad effect on it. You need to quit if you need to live long and healthy. Okay, sometimes the motivation can come from there. Okay, so seek help from a physician, spend some time just talking about this. Okay, and then develop a proper tobacco cessation strategy. There are a lot of centers that engage in this. There are a lot of physicians, doctors, psychiatrists who engage in tobacco cessation. Seek help. Don't try to do it alone. There are mobile helplines that have been developed to help in cessation. Seek help. Don't do it alone, because you will definitely fail if you try it alone. Okay, you need the help of your family and you need the help of a physician to quit.
Right.
So, with respect to tobacco and chewing, to conclude, if you have to give a one sentence message to our subscribers, what would it be?
Tobacco kills 50% of its users. So, 1 in 2 tobacco user will die of a tobacco related illnesses. Now, if you want to cure tobacco related illnesses, you have to prevent against it. Prevention is the only cure. Never pick up the habit. And if you've picked up the habit, quit today, because even after you quit, you will remain exposed to their toxins. You will remain vulnerable to developing tobacco related illnesses for up to 15 years.
Right.
Yeah.
Thank you so
Very,
much.
very, very interesting, and thanks for your valuable insights.
Thank you so much.
And this is a very important and burning topic at this point of time. Thanks for coming on our show.
Thank you so much.
Okay.
Thank you.
Thank
Thank you.
Thank you.
Thank you.